CME online program this evening. We are going to be having a program that will provide 1 hour Category 1 physician AMA CME, as well as 1 hour of Virginia Nurses Association CE credit. Sovah Health is accredited by the Southern State CME Collaborative and the Medical Society of Virginia to provide Category 1 AMA CME for physicians. It's also accredited by the American Nurses Association and the Virginia Nurses Association to provide accredited CE credit for nurses, nurse practitioners. The program this evening is designed to promote uh, two desirable physician attributes, that is, our providing patient-centered care and employing evidence-based medicine in our practice. The needs assessment for this was the relatively high prevalence of colon cancer in the general population and the tremendous value for early detection through screening and the various types of screening mechanisms that are currently available. Dr. DeWitz and myself and members of the Sovah Health CME Committee have no commercial relationships to report to you this evening. This program has no commercial support. It is supported instead, as are all of our CME and CE programs, by the Ralph Landis Medical Education Fund that resides at the Danville Community College Educational Foundation. This fund was established when Dr. Ralph Landis, the founder of the local urological and nephrology clinic here in Danville, uh, donated a significant amount of money to the hospital to create a fund to support medical education for all types of healthcare professionals in our community. You will receive an evaluation form at the end of this program. There are two ways that you can access it. Vinay will put a QR code in the chat at the end of the program, as well as a link you can click on. The evaluation form is something that we take very seriously. It is required for nurses and nurse practitioners in order for you to receive credit for your participation in the program this evening. On that form, you'll find some 7 questions. Number 4 is one that we want to make you especially aware of. It asks, what changes will you be making in your practice based on what you learned this evening? That's a very important question for everyone. It's not just for the physicians or providers. It's for everyone that attends, because we all practice our craft within our scope of practice. So take a few minutes and complete the eval form, if you will. One thing to be sure you're aware of is to complete the eval form, you'll be asked to re-enter your full name and your email address. It's important we get your full name, because that's what will appear on your certificate of attendance or participation this evening. So please don't use a nickname, a cute name. Please use your full name for us. Also, if someone else is with you this evening, listening or viewing the program, which they are welcome to be there, please let one of us know that, so we can be sure they receive credit for their attendance this evening. For the new medical residents on the call, and I want to welcome each of you. For those of you who may or may not be aware, we have a new group of family medicine, internal medicine residents, a total of 18 new physicians joining our programs as of the first of this month. And we're delighted to have them attend. For the residents on the call, our residents, please be aware you do not have to keep up with the certificates that are issued after the program. Your coordinator, your CME residency coordinator, tracks these for you and keeps a list of the ones you have attended. I also like to always at this point send a thank you to Vinay Mayo, who helps me organize the program. She does all the really heavy lifting that allows us to get these programs done. And Connie Plaster, who leads our nursing educational activities, has just joined us in this effort, and together they make it possible for us to have these programs each month. Dr. Daziwi is going to urge you to ask questions, interact with her. She's going to take a couple of breaks and ask for questions, but if you have a question, please feel free to just type it in the chat. Vinay will be monitoring that, and she will feed them forward to to her as we go through the program. Let me make you aware of a couple of other programs we're doing this month. We typically in the past have not done programs in mid-July and August due to people being away, but we've had so many requests for different topics that this year we felt we should, if you will, just go right on through the summer. We're going to have a program each Thursday night in July following tonight. Next week, we're delighted to have Dr. Cameron Wolf. Dr. Wolf is at Duke. He is the point or medical director for Duke University Health System's Emerging Pathogens Unit. He is the guy that decides what to do when there's a viral outbreak, like when COVID came in 2020. He led that management program. And he's going to be talking with us about currently emerging viral infections, particularly with a concern about the Ebola virus that has been active in Africa. With air travel and all the things that people do currently, it's not unrealistic to be worried that that could end up being a threat even in the United States at some point in the not too near future. And then the third program in July is a week later on July 23rd. Dr. Natalie Wong, another gastroenterologist at Duke, is going to be talking about an update on inflammatory bowel disease. This topic was requested by our medical staff on our survey we do every year for important CME topics to be covered. So I hope you'll be back with us next Thursday and the next Thursday as we work our way through the month of July. This evening, I am delighted to have Dr. Jennifer DeZiewis as our speaker. She is a Duke-based gastroenterologist. She is originally from Rochester, New York, and she began her educational journey at the University of Rochester with her bachelor's degree in epidemiology, which she earned with highest distinction. After that, she completed a master's in public health program in epidemiology, also at Rochester, and then went to medical school, receiving her MD from the University of Rochester School of Medicine and Dentistry. However, at that point, she came to Duke, where she did her internal medicine residencies and then completed her GI fellowships at the Wake Forest University School of Medicine, Atrium Health, North Carolina Baptist Hospital in Winston-Salem, where she was selected as chief fellow, which is a distinct honor if you're in a fellowship program. She has numerous peer-reviewed, high-impact journal publications, and she has a practice for the Duke Group. Hers is based at one of their Raleigh centers. But we're delighted to have her this evening. So, Dr. DeZiewis, if you'll bring up your slides, you'll knock mine off, and we can get going. Thank you so much.
All right, thank you so much for that introduction. Can you all hear me?
Yes, ma'am.
All right, great.
There you go. If you'll just go to full screen slideshow, you'll be.
Scanning.
There you go. Looks great. Thank you.
I'm looking for my presenter view. Let me try again.
We're not seeing your slides currently. We were a while ago.
Yeah, I'm looking for my presenter mode. Didn't happen when we tried it out. Let's see.
There you go.
Are you all seeing the full screen, including the notes?
We're seeing the presenter mode with your
Yeah.
notes at the bottom.
With the notes at the bottom. That's
Yeah,
what
we
I'm
need,
looking
we
at.
need to get to full screen.
Yeah.
So go over to your left and hit from beginning.
Uh-huh.
Uh-huh.
There you go. Looks good.
But I'm not able to see my notes currently. That's my problem right now.
Well, just speak from your heart, don't worry. Not a problem.
Let me try one more time. No. Sorry, y'all. I don't know why it's looking different than when we tested this out. Let's pull it up separately. All right, let's see if this works. Can you all see that?
Yes, ma'am.
All
Looks
right.
good.
Very good. Thank you all for your patience. So thanks so much for that introduction. I do not have any disclosures. The objectives of my talk are going to be going over why colorectal cancer screening matters. I'm going to review the American College of Gastroenterology 2021 key recommendations. I'll specifically focus on screening modalities and intervals of these screening tests. I'll then go over the American Cancer Society 2026 updates. I'll take a moment to talk about the role of blood-based testing, which is new on the horizon. And then finally finish with some practical approaches for primary care. So why does screening matter? Colorectal cancer is actually the second leading cause of cancer-related deaths in the United States. In 2026, colorectal cancer is estimated to account for over 150,000 new cancer diagnoses and approximately 55,000 deaths. And to put this into more tangible numbers, the lifetime risk of colorectal cancer in men is 1 in 23 and women 1 in 25. There's an increasing rate of colorectal cancer in those younger than age 50, largely because of increasing number of distal colon as well as rectal tumors. Epidemiologic analyses indicate a birth cohort effect underlying the rising increase in colorectal cancer in younger adults, with successive generations born since 1950 demonstrating higher risk at earlier ages than preceding cohorts. And although we don't know all that much about this, this appears to be multifactorial in origin, Prenatal and early life exposures, poor diet, lack of fiber, lack of exercise, tobacco use, alcohol use, antibiotic exposures, and metabolic syndrome have all been hypothesized to cause carcinogenic changes to the gut microbiome, leading to more advanced polyps and cancer. There are also notable racial and ethnic disparities in colorectal cancer detection as well as survival. Age-adjusted colorectal cancer incidence rates are estimated to be 11% higher among African American individuals, and their mortality rates 40% higher compared to white individuals. American Indian and Alaskan Native populations have the highest burden, with incidence rates 48% higher and mortality rates 44% higher than white individuals. The principal goal of colorectal cancer screening is, of course, to reduce the incidence and mortality through detecting and removing precancerous lesions before they become a problem. Screening is crucial as colorectal cancers may not cause any symptoms at all, particularly in its early stages, so screening is the only reliable way to find them before they can progress. And we also know that detecting colon cancer early dramatically increases the chance of survival. And in the United States, the 5-year survival rate for those diagnosed with localized colorectal cancer is over 90%. A little bit about colon polyps themselves. We know that colorectal cancer starts in a benign growth or polyp arising from colon mucosa. Most cancers develop through the adenoma-carcinoma sequence. If there's malignant cells within the polyp itself, it's termed carcinoma in situ or an intramucosal carcinoma. And these types of lesions can be resected with what's called EMR or endoscopic mucosal resection during time of colonoscopy. Once malignant cells invade into the submucosa, so one layer down, a true colon cancer is present. These cancers are labeled as T1A or T1B lesions based on the depth of invasion into the submucosa. And the reason why this matters to us as gastroenterologists is that T1A lesions can typically be resected endoscopically with what's called ESD or endoscopic submucosal dissection. And T1B lesions can typically be resected with endoscopic full thickness resections or EFTR. Now, ESD and EFTR are considered advanced GI procedures that only a handful of gastroenterologists that do perform, and I'm not one of them. Once a cancer is invading into the muscularis, it's considered a T2 lesion at least. And although there's some emerging evidence that endoscopic full thickness resection can be considered to address T2 lesions, traditionally surgery, including lymph node dissection, is recommended. So these are all different types of colon polyps that we encounter during colonoscopy. They come in all various shapes and sizes. Box A is the most typical type of polyp that we come across. This is a small adenoma that can be easily removed with a cold snare at the time of colonoscopy. Box B is a 4-centimeter advanced adenoma. We call it an advanced adenoma because it's at least 1 centimeter in size. These polyps can sometimes be tackled during the time of a colonoscopy, but often we end up bringing people back, particularly if they're large polyps, for an EMR resection. Box C is an adenoma with invasive cancer, and the arrows are pointing to an area of dimpling and ulceration that suggests more advanced cancer. Box D is a sessile serrated polyp. These lesions are often flat and can be challenging to detect if a bowel prep is poor. They also are often seen in the right colon. Box E is a sessile serrated polyp with some dysplastic features. The reason why that polyp looks a little bit different is that the scope is on narrow band imaging, which allows us to see the blood vessel pattern a little bit better. And as you can see, there's some abnormality of the blood vessels there, which suggests dysplastic tissue. And finally, box F is a sessile serrated lesion with invasive cancer. there's complete obliteration of the normal blood vessel pattern. So who should we screen and when should we screen them? The American College of Gastroenterology recommends initiating colon cancer screening for average risk men and women at age 45. This is an important change from the 2009 guidelines that had previously recommended screening start at age 50. Screening should continue through age 75 for eligible patients. For ages 76 to 85, the decision to screen should be based on a patient's overall health and screening history. And screening in this age category is thought to be most appropriate for those not previously screened, those healthy enough to undergo treatment if a cancer is seen, and those without substantially limited life expectancy. For adults ages 86 years and above, screening is no longer recommended because of competing causes of mortality. There are also risks related to performing colonoscopy, particularly in elderly patients. And these risks vary from dehydration and electrolyte disturbances during bowel preparation, having to hold anticoagulation or antiplatelet agents, risk of perforation, risk of major bleeding, and peri-procedural cardiovascular events. All that being said, I find that many patients can feel pretty strongly about continuing colonoscopy, and folks don't really like being told that they're, quote, too old for a test that was previously recommended for them to undergo. And in these cases, I often bring patients into clinic to have a very thorough risk versus benefit discussion about colonoscopy, and find that most patients ultimately elect to stop, particularly if prior colonoscopy showed no or very low risk lesions. So how should we go about screening? Stepping back a little bit, the ideal screening test has to have high sensitivity, high specificity. It's ideally convenient, non-invasive, safe, inexpensive. And I can't really think of a test that meets quite all those criteria, but it's nice to check as many boxes as possible. I'll take a moment to remind everyone of the definitions of sensitivity and specificity, as I'll be using these terms quite a bit for the remainder of the talk. Sensitivity is the true positive rate. A test with high sensitivity can detect most individuals who have the condition, minimizing a false negative. Specificity is the true negative rate. A test with high specificity accurately identifies those who do not have the condition, minimizing false positives. And in many instances, the best screening test can be considered the one that's acceptable to the patient and gets completed. The American College of Gastroenterology categorizes screening modalities as either one-step or two-step. And for one-step, also direct testing, the only option is colonoscopy. Colonoscopy is both diagnostic as well as therapeutic. During the procedure, we're able to look for lesions and resect them if we find them. Two-step testing, as the name implies, of course, starts with a less invasive screening measure, however, requires colonoscopy for follow-up if it's positive. Examples of two-step tests are the stool tests, blood tests, flexible sigmoidoscopy, CT colonography, and colon capsule. The ACG 2021 guidelines includes this table that summarizes the performance, the pros, and the cons of each of the screening modalities. So I'm going to take the next couple of slides to break them down test by test. And we'll start with colonoscopy. Colonoscopy is the most commonly performed gastrointestinal procedure in the United States. It not only allows for the near perfect detection of colon cancer, but also the detection and removal of polyps that risk becoming cancer in the future. A systematic review of 6 very large observational studies reported a pooled reduction of 69% in overall colorectal cancer incidence and reduction of 68% in colorectal cancer mortality with screening colonoscopy. An advantage of colonoscopy is that if it's completely normal, it can be repeated again in 10 years, which is a really long time. Disadvantages of colonoscopy is that it is an operator-dependent procedure. So you're relying on the colonoscopist to do a good job. The patient, of course, has to undergo a bowel prep, and there are some risks of serious complication associated with colonoscopy, though these risks are overall quite rare. Let's move on to stool and blood-based tests. FIT uses an immunoassay technology to detect the presence of human hemoglobin in stool samples. It's 79% sensitive, 94% specific for colorectal cancer detection. It's non-invasive, there's no risk of complications, and it's convenient. Patients can do these at home. Disadvantages are that if it's positive, you need a colonoscopy. This test also has to be done yearly, making compliance also quite challenging. Notably, FIT testing has low sensitivity for advanced adenoma detection and does not detect serrated lesions. And we know these serrated lesions are thought to account for 20 to 30% of colon cancers. So as you see, FIT is not without its issues. Next is multi-target stool DNA testing. It's an FDA-approved stool test that comprises an assay for mutant KRAS, methylated BMP3, and NDRG4 proteins, as well as FIT. It's 92% sensitive, 87% specific for colorectal cancer detection. It again is non-invasive, there's no risk of complications, and it's convenient. It is better sensitivity for advanced adenoma and large serrated lesions compared to FIT alone. However, disadvantages include a higher false positive rate, meaning that the test may be positive, however, colonoscopy ultimately negative. And stool DNA testing does need to be repeated every 3 years and is more expensive than FIT testing alone. Septin9 is a blood-based test assay, which may be appropriate for those who refuse other colorectal cancer screening methods. And we will go over blood-based assays in greater detail later on in the presentation. Flexible sigmoidoscopy is another option for colorectal cancer screening. The scope we use for this procedure is about 60 centimeters in length, which is much shorter than the standard colonoscope, which is 160 to 170 centimeters long. We are therefore only evaluating the colon up to the sigmoid flexure. And although flexible sigmoidoscopy is highly sensitive for distal colorectal cancer detection, we're not evaluating the right side of the colon. If polyps are found, referral for a full colonoscopy is required. And you'll see on the table, it notes that flexible sigmoidoscopy requires enema preparation. However, I would argue that to get really good looks at things and resect polyps, it's really best to have a complete bowel prep. CT colonography, also known as virtual colonoscopy, uses a low-dose CT imaging study to examine the colon and rectum. This is done through the radiology department, and they insert a small tube in the rectum to gently insufflate the colon with air or carbon dioxide. Then a CT scanner takes images while patients lie on their back and stomach, and a radiologist reviews the images looking for polyps, cancers, inflammation, or any other abnormalities. The study is highly sensitive for colorectal cancer detection, but much more variable for polyps or flat lesions. And though we don't routinely recommend CT colonography as gastroenterologists, The niche that they're very helpful in is when we're not able to complete a full colonoscopy for one reason or another, like a patient's body habitus or significant scope looping or tortuous colon. And in those circumstances, the patient's already had a bowel prep, and we're sometimes able to get the patient in for CT colonography later that day to, quote, clear the colon. And now, if something's found on that CT scan, then a repeat colonoscopy with some additional equipment like a different scope or an overtube or rarely double balloon is needed. And finally, colon capsule is listed. I really don't have any experience with colon capsule. This is not something that we offer at Duke, at least routinely. But for completion's sake, this test does have high sensitivity and specificity for detecting cancers and polyps. It is considered minimally invasive. However, it does again require a bowel prep. And of course, a positive exam requires colonoscopy. And looking into this a little bit more, it seems like many insurance carriers do not cover this test for routine screening purposes. Now, though all the tests we reviewed are options for colorectal cancer screening, the ACG does make some specific recommendations on which tests are best. The ACG notes that colonoscopy and yearly FIT testing should be the primary preferred screening modalities. And as you may know with these types of published guidelines, there's an associated scale of strength of recommendation as well as quality of evidence. This recommendation by the ACG is rated as strong with low quality of evidence. Flexible sigmoidoscopy, stool DNA testing, CT colonography, and colon capsules should be considered for those who are unwilling to undergo colonoscopy or yearly FIT. And this recommendation is considered conditional with very low quality of evidence. Now, screening for colon cancer is more complicated for patients that are not considered average risk. For patients that are at increased risk, colonoscopy is often the only appropriate colon cancer screening test, at least up front. It's estimated that up to 10% of US adults have a first-degree relative with colon cancer. Family history of colon cancer is believed to be associated with at least a twofold increase in personal colorectal cancer risk, and the magnitude really depends on the age at diagnosis of relatives affected. The younger the relatives, the higher the risk. The ACG recommends that for individuals with colorectal cancer or advanced polyps in a first-degree relative, age less than 60, or colorectal cancer or advanced polyp in at least 2 first-degree relatives at any age, screening colonoscopy should be initiated at age 40 or 10 years before the youngest affected relative, whichever is earlier. Repeat colonoscopy is then recommended every 5 years if there are no findings. The ACG recommends that for individuals with colorectal cancer or advanced polyp in a first-degree relative at age at least 60, colorectal cancer screening, ideally with colonoscopy, should be initiated at age 40 or 10 years before the youngest affected relative. And if normal, then that patient can resume average risk screening, including the stool studies. It's important to maintain a high index of suspicion for inherited colorectal cancer syndromes, and genetic evaluation should be considered for patients with a very high familial burden of colorectal cancer. And I will note that all these recommendations regarding special populations are considered conditional with low or very low quality of evidence. For optimal performance of any diagnostic test, it's imperative that quality control programs and monitoring be in place. We know that colonoscopy is highly operator dependent, and therefore there are benchmarks to ensure high quality colonoscopy is being done. The ADR, or adenoma detection rate, is an important marker that we track as gastroenterologists. It represents the proportion of average risk patients undergoing screening colonoscopy in whom an adenoma is found. And it's regarded as a robust measure of colonoscopy performance that correlates with subsequent cancer risk. We aim for at least 30% for male patients and 20% in female patients for any screening colonoscopy, or in general, 25% overall. We also aim for a cecal intubation rate of at least 95% for our screening patients, meaning that we're able to reach the maximal intended extent of colonoscopy, which is almost always the cecum. Our withdrawal times should be at least 6 minutes, with 2 looks in the right colon, where polyps can hide in the ascending colon and hepatic flexure. Now, some of you may ask about baby aspirin and if it still has a role. The ACG says that daily low-dose aspirin should be started for individuals between the ages of 50 and 69 with a cardiovascular risk of at least 10% over the next 10 years, who are not at increased risk of bleeding and who are willing to take aspirin for at least 10 years. There's a lot of criteria there. This is considered a conditional recommendation with low quality of evidence. The evidence has come from a 2016 USPSTF performed systematic review of primary and secondary prevention trials of cardiovascular disease to evaluate the effects of aspirin on colorectal cancer incidence and mortality. And they found no effect on the colorectal cancer risk within 10 years of starting aspirin. However, after 10 to 19 years of being on aspirin, there was a 40% reduction in risk for colon cancer. The authors note that it's important to know that the included studies generally did not report or break down results by colorectal cancer screening history, and therefore it's not quite clear of whether long-term aspirin use provides further incremental benefits to standard colorectal cancer screening, and whether benefits are outside or outweighed by risks such as bleeding. And aspirin therapy is not something I put much emphasis on when I see patients in clinic. So how can we improve screening efforts? Surprisingly, there are more than 20 million Americans eligible for colorectal cancer screening who have not been tested as recommended. This equates to about 1 in 3 adults. Over the past 5 years, there have been several national campaigns to help improve awareness of colon cancer screening, with examples including 45 is the new 50 slogan championed by the American Cancer Society, and also March is Colorectal Cancer Awareness Month. Health systems have integrated chart flagging systems, and patients are able to check their MyChart accounts if they're up to date on screening or surveillance exams. At the provider level, the involvement of primary care providers is critical, as PCPs often are well known and trusted by their patients, and they can provide counseling regarding the various screening options and help patients select the appropriate and likely to be completed test. And in fact, studies have shown that patient-provider communication regarding screening improves screening uptake. And in fact, in one cross-sectional study, provider explanations and greater provider encouragement was associated with the patient selecting colonoscopy as opposed to other screening tests. All right, so that pretty much wraps up the ACG guidelines. Are there any questions on what I've spoken about so far?
Renee, is there anything in the chat?
No questions are in the chat.
Okay, progress on.
All right, so we'll have plenty of opportunity for questions at the end. All right, so more kind of hot off the presses. In March of this year, the American Cancer Society released an updated guideline for colorectal cancer screening. These guidelines made headlines as the development group put an emphasis on some of the newer molecular-based screening tests, which include a multi-target stool RNA test, a next-generation stool DNA test, and a blood-based cell-free DNA assay. And Dr. Robert Smith, the Senior Vice President of the American Cancer Society, stated, by offering more screening test tools in our guideline update, more eligible adults will be able to participate in life-saving colorectal cancer testing, helping to close the screening gap and catch more cancers at an earlier treatable stage. Now, while there are some differences in these guidelines compared to the 2021 ACG guidelines, many of the core recommendations are thankfully consistent. So the ACS reaffirms the recommendation that average risk adults should initiate colorectal cancer screening at age 45 and continue through age 75. Again, adults ages 76 to 85 should discuss continuing screening with their healthcare provider. And those over the age of 85 or with a life expectancy of fewer than 10 years, screening should stop. The ACS does emphasize that the most effective screening test is the one the patient completes and does recommend offering patients a choice between stool tests and a direct visual exam. They do, however, again, say that colonoscopy remains the gold standard. Now let's go through some differences. The ACS lists yearly FOBT or fecal occult blood testing as an option, whereas the ACG did eliminate FOBT altogether on their 2021 guidelines. And this is because FOBT testing requires dietary and medication restrictions, whereas FIT testing does not. So it's kind of thought to be a bit inferior and outdated at this point. Yearly FIT testing, of course, is on the list. The next generation multi-target stool DNA test is an updated version of the already recommended stool DNA test. And the revised assay was designed to improve specificity while preserving high sensitivity for colorectal cancer detection, meaning reducing the rate of false positive tests without sacrificing the ability to correctly identify true high-risk lesions or cancer. A multi-target stool RNA test was approved by the FDA in 2024. This test uses an algorithm based on a combination of 8 RNA transcripts, participant reporting smoking status, as well as FIT. This platform has high sensitivity for colorectal cancer detection, however, moderate sensitivity for advanced polypoid lesions. And similar to stool DNA testing, stool RNA testing has lower specificity compared to FIT. The screening interval for RNA testing is uncertain, however, currently recommended to be repeated every 3 years. A new blood-based test for colorectal cancer received both FDA regulatory approval and a Centers for Medicare and Medicaid Service Coverage determination in 2024 for screening average risk individuals. This test uses an emerging technology for detecting DNA fragment patterns, aberrant methylation, and genomic alterations associated with colorectal cancer. 20 algorithms constructed with AI and machine learning are then classifying results as either positive or negative. To date, there have been 2 large cohort studies evaluating the performance of blood-based testing, one of which had over 27,000 participants. Sensitivity for detecting an advanced stage cancer is quite good. It's 84%. However, the test performs quite poorly for the detection of early stage cancer as well as advanced polyps. So for example, sensitivity is only 60% for detecting stage 1 cancer and only 13% for an advanced adenoma. So there are real concerns that blood-based testing may limit reductions in colorectal cancer incidence and mortality. And the worry is that patients previously undergoing average risk screening with colonoscopy or stool-based tests will instead select the far inferior blood-based test because it's easy. And the ACS makes clear that for blood-based testing uptake to reduce colorectal cancer mortality at the population level, it must preferentially engage individuals who would otherwise remain unscreened. All right, so some practical primary care takeaways. Start average risk screening at age 45. Identify high-risk patients early and refer them for colonoscopy. This, of course, requires patients to know about their personal as well as family history. So encourage your patients to ask their family about colonoscopy results, including the size and the histology of polyps. And this really does matter because if a family member has an advanced polyp, meaning a polyp at least 1 centimeter in size, or villus histology, or advanced dysplasia, or if a family member, of course, has colon cancer, then screening may need to start sooner at age 40 or sometimes even earlier. Colonoscopy remains the gold standard test for colorectal cancer screening and therefore should be prioritized if at all feasible. Use FIT, stool DNA tests, or blood-based tests to increase participation. And of course, ensure completion of follow-up colonoscopy after a positive result. And this should ideally be completed within 6 months. Now, I recognize that the purpose of this presentation is reviewing colorectal cancer screening guidelines, but I did want to include a couple of slides about surveillance colonoscopy. A colonoscopy is considered surveillance once a patient has a history of polyps. And it's ultimately the responsibility of the colonoscopist, after reviewing pathology results, to make a recommendation on when a patient should return for surveillance colonoscopy. And honestly, we do this day in and day out. So we essentially have these guidelines memorized, but I've included the schematic as a reference for you all. As you can see, if colonoscopy is normal, we recommend repeat in 10 years. If 1 to 2 small polyps, then we often recommend either 5 or 7 years based on if a polyp was a tubular adenoma or a cell-serrated lesion. If 3 to 5 polyps are found, we bring back patients in 3 to 5 years. If 5 to 10, or if a polyp is at least 1 centimeter in size or has advanced histologic features, we bring folks back in 3 years. If there's more than 10 polyps, we bring back them in 1 year. And although it's not listed here, if we're removing a pretty large polyp in a piecemeal fashion, we often bring these folks back in 6 months.
Dr. DeWitz, we have a question. Do you know if a patient has a positive Cologuard and won't have a colonoscopy, should we repeat the Cologuard in 3 years if we can?
That's a very good question. I guess it would kind of depend on why a colonoscopy, why the patient either doesn't want to undergo colonoscopy or if it can't undergo colonoscopy. Because really, once there's a positive Cologuard test, colonoscopy is the only appropriate follow-up, with the concern that there is underlying colon cancer.
Thank you. And do you know how this is applied to those incarcerated in prison?
Meaning whether folks in prison would still have the same ability to get screened? Is that the question?
Would you like to specify, Dr. Spillman?
Sure, thank you. And Dr. Moore knows I ask weird questions with public health, but we do help with certain things with with those incarcerated long-term, not
Mhm.
detainees in jail, but in prison, those with convictions. And I was just curious if you know how this is applied to the entire process of them. How does you might or might not know how the prisons handle this. They might have a way to handle this, but depending on perhaps the nature of the reason for the incarceration,
Mhm.
how is this handled in the academic area or in the GI area um, about making this happen and keeping everybody safe and yet getting effective results. And I say that because some people are incarcerated for general felonies that are non-violent. Others are violent, and I didn't know how if there's some. Ideally, we would want to have everybody screened the same way or treated the same way, but there are extenuating circumstances. I didn't know your experience with this. Thank you.
Yeah, great question. I haven't dealt with that specifically for screening colonoscopies, though I do see patients in clinic. I see patients with general GI issues as well as inflammatory bowel disease. So I've seen folks that are coming from prison to see me for, various GI concerns, including IBD. And my recommendation is not going to change based on if they're an inmate or not. I'm going to do what I think is,
Right.
best for the patient. And I've, ordered a colonoscopy or ordered an MRE to be done. And at least for the person I'm thinking about, it's currently scheduled. They came to clinic with one guard and there was no issues at all.
Okay.
Yeah.
And it was more a question not of if, but how. And because I
Yeah.
know that when COVID, the C word, the other C word was around, we had issues with how to interact with prisons, and there were other types of things as well. So I just didn't know how this would impact. Not that you would make any different recommendations, because then it's up to the prison system to make that fall through, but just how that happens. I'm thinking more along the lines of someone who's a difficult prisoner. Thank you.
Yeah, great question. I do wonder if certain systems may employ more of the, um, the stool test to start things out, and if that's positive, then refer to colonoscopy. I don't know that answer. I haven't come across that quite yet, but great thought.
Thank you.
And not to get too into the weeds here, but you all may ask that if a patient's polyp history may change the standard surveillance recommendations. And the short of it is that yes, it can certainly. So this is where it gets a little bit more nuanced and complicated, but we do reference this table quite often as gastroenterologists, as it includes recommendations on when to bring patients back for repeat colonoscopy based not only on their baseline findings, but as well as the findings at the time of their first surveillance colonoscopy. To walk you all through an example, so for instance, if a patient had an advanced polyp on their index colonoscopy, let's say it was at least 1 centimeter in size, however, on their repeat colonoscopy in 3 years, it was completely normal. This patient would only get 5 years until their next colonoscopy, not the full 10, for instance. And again, this is the job of the gastroenterologist or surgeon performing colonoscopy to make a recommendation and when to bring a patient back. But I'd encourage you all to reach out to the physician performing the procedure if you have questions about what was seen or the surveillance interval recommended. All right, and I wanted to finish with some common misconceptions possibly of colonoscopy that patients may have, and some tips to hopefully help you all work through some of these concerns when you see folks in clinic. Some folks may think that the procedure itself is the worst part, But in reality, the great majority of patients actually report that the bowel prep, not the colonoscopy, was the worst portion of the experience. Tricks to make the prep more tolerable, though it's still not great, include making it very cold, drinking it through a straw, rotating sports drinks that it's mixed in. And for patients that have kind of pre-existing issues with nausea, I often prescribe Zofran for folks to have on hand during the bowel prep, and that's quite helpful. Some people may worry that colonoscopy may be too painful or it's too dangerous. And while fear of pain and discomfort is a leading barrier to colonoscopy, the possibility of a serious complication is quite rare. So major bleeding occurs in approximately 8 in 10,000 colonoscopies, and perforation occurs in approximately 4 in 10,000 colonoscopies. The fear of pain is also often disproportionate to the actual experience with modern sedation practices. At Duke, we do almost exclusively use propofol, which is administered by our anesthesia team. So our patients are completely asleep when they're on propofol. And most patients describe like the best nap ever. We also use carbon dioxide for colon insufflation rather than oxygen. So people are less crampy and have less discomfort post-colonoscopy. And finally, there may be some uncertainty about if insurance is going to cover colonoscopy, and insurance carriers will absolutely cover screening colonoscopy. It's mandated under the Affordable Care Act. However, there is a little bit of nuance as cost sharing may still apply when a screening colonoscopy becomes therapeutic. And similarly, for surveillance colonoscopy, there may be a cost sharing component for certain insurance carriers.
Dr. DeWitz, we have a question. Are there any good resources for preventive action like your diet or social?
Meaning like before undergoing colonoscopy?
Can you clarify, David Reed, please?
Sorry, that was my question. Hi. This may be a little bit out of the way. I was just sort of wondering, since we're talking about screening, and I know a lot of this is genetic anyway, are there any actions that we in clinic can advise our patients to take in the way of preventing development of these polyps that may change?
Yeah, that's a really good question. I get asked that all the time after colonoscopy, like whether, they did anything wrong or it's something that they can do to prevent more from growing. And exactly as you point out, I do say that there is a large genetic component to this. Things that have been shown to be associated with polyp growth and cancer are processed foods, red meats, not having enough fiber in your diet. So in general, I say, eat healthier, get enough fiber, exercise, do all like the healthy things that are pretty much beneficial for any medical issue. But the biggest links have been to processed foods and red meats.
Thank you.
Yeah. And that actually wraps up my slides, so I'll be happy to take more questions.
Do we have other questions from anyone on the call tonight? Let me ask one thing to clarify things, and you may have said this, so I apologize if I'm asking this over again. If a patient has a first-degree relative who had what they were told was a benign polyp, is that situation to where that is now a high risk for that patient? Or does the original person, the relative, have to be told they had an adenomatous, villus, or precancerous? In other words, it's just having a relative with a simple benign polyp resected, that's not puts them in a high risk position. Is that correct?
Yeah, I think what gets tricky is the terminology, because even a larger polyp that's considered what we call an advanced polyp is still technically on the spectrum considered benign. So it's really, I think, challenging to figure out exactly what patients mean, or even what we as physicians mean when we say benign, I guess. So it's most helpful if patients know specifically if their family members have large polyps or villus histology. That's most helpful. I will say that I ask the question all the time to my patients when I'm consenting them for procedures about their history and family history, and most people don't know the exact specifics. But the more they know, the more helpful it is. Absolutely.
And again, a lot of times they aren't told specifically, or they don't hear what specifically was said. It's just, oh, it's not cancer, and they're happy, and And I'll re-echo something you said, having had several colonoscopies, nothing beats some propofol. You can understand why Michael Jackson loved it. It's you sleep better than you've ever slept. It's a good time. So
I literally hear Michael Jackson's name, I don't even know how many times per week.
Yeah.
Because of that.
Yeah, it's good sleep. But at any rate, do we have any questions on the call? This has been a really, really good session this evening.
Awesome.
I so appreciate all the comments and things. But you have the expert right here if you've got questions about patients or situations. We don't want to get into HIPAA issues here with specific patients. That just popped up from one of our family medicine docs. Vinay, you want to read that from Dr. Shaw?
Yes, I'm looking at one from Sally Ann McIntosh. She said, "Good evening, Dr. DeWitt's excellent presentation with timely refreshers. How are clinical workflows adapting to ensure patients who test positive with new blood and at-home stool tests actually complete the essential flow-up colonoscopy with the recommended timeframes of 6 months? What has your experience been so far?"
I will say that in terms of like getting patients in for colonoscopy, at least at Duke, I feel like we do pretty well. I'll see patients for a positive Cologuard for their colonoscopy within usually a couple of months, if not even quicker. Particularly if they're otherwise pretty healthy and can be done at an ambulatory surgical center. We have quite a bit of access, and we're usually getting people in very quickly. It gets a little bit more complicated if you're looking for a hospital spot. That being said, I have primary care doctors reach out to me, and we have folks that find slots if need be for something like a positive test. So we need to get in within 3 months, 6 months at most is where I like to push it out to. But I will say that if something does delay a patient getting in, it's when you look at the records, it's usually patients not picking up the phone or not getting scheduled, or maybe they got scheduled and then canceled. In fact, I had one the other day that was a positive Cologuard that dropped off my schedule. So I don't know, even really what happened there. And from Duke's perspective, those patients go back into a pool and they get called to reschedule, but after a certain number of times, the scheduling department stops reaching out if they can't reach someone, which is, I'm sure, very challenging for you all too. When you see a test turn positive and then patients don't get their colonoscopy.
And we have another question. Do you recommend to hold of any meds before a Cologuard?
For Cologuard, I don't think you have to hold any. Yeah, there's no medication or dietary restrictions. I do say that if people are having, obvious bleeding from like hemorrhoidal irritation, that's going to turn that Cologuard positive. So if you're in like a hemorrhoid flare, then that's not the most appropriate time to do a Cologuard test. But if that patient has had rectal bleeding and has never had a colonoscopy, and they're, like pretty sure it's from hemorrhoids, that makes me uneasy. That patient needs a colonoscopy because they had rectal bleeding. They may think it's from hemorrhoids, but God forbid there's something else going on, like a rectal cancer.
And what about evidence for third-degree relatives, like a first-degree cousin who have colon cancer for screening purposes? The guidelines focus on first and second-degree relatives.
Yeah, absolutely. In fact, the guidelines don't give too much recommendation, too much guidance on even second degree relatives. So what I find is that many of my patients will report several second degree relatives, or like you mentioned, a third degree relative with colon cancer. And you kind of have to take it in the entire like patient's history and try to figure out, does this ring alarm bells for some sort of colorectal cancer syndrome? If so, then refer to genetics for discussion on whether testing should be done. But I think most gastroenterologists in practice, if they're hearing multiple second, multiple third degree relatives with colon cancer, we're often, saying let's bring you in, earlier, maybe at age 40, to start your screening. But that's not standard guidelines.
Any other questions? We have anything else, Renee, in the chat?
No other questions in the chat, other than thank you for an excellent program.
Anybody else on the call? Speak up now, please. You have a question, a comment, concern? Okay, well, we are right on time, and Dr. DeWeese, thank you so much. Great job on this, and thanks everyone being on the call. Next week, we'll have Dr. Cameron Wolf here, same time, same station, talking about emerging viral illnesses, and particularly Ebola, hantavirus, and maybe something about this new foodborne parasite that's just hit the news also. I haven't mentioned that to him in our emails, but I will. Remind you that when you do the eval form, Renee will be putting that in the chat if she's not already done that, a link on a QR code and or a link that you can copy and paste to your browser. Be sure and use your full name. We have at least 2 people on the call tonight who put just their first name. So when you fill that out, please put your full name so we know you're here. Thanks so much for being on the call. Have a great evening. Try to stay cool. And we look forward to seeing everyone back in a week. Bye-bye. Take care.